thank you very much for the opportunity to talk to you. I'm Frans Cronje. I'm Associate Medical Director of the Baromedical facility, which is essentially a hyperbaric chamber and support for the diving and underwater medicine, BSc, Medici honours programs and so on. So I do that part-time. But the reason for talking to you today is really to give you a bit of an insight, if you like, into the world of baromedicine. Now, we need you. So we have a tremendous need clinically for the input of physicians and pulmonologists in our respective fields, be they occupational or operational. So I hope what I'll achieve this morning is to give you a kaleidoscope of what the environment looks like from different perspectives. And then my goal is very selfish. My goal is really to provide you enough information so that you know our needs clinically, and maybe it would also be helpful for you to just have that additional perspective which has applications in your regular jobs as well. So by the way, just this picture is the ultimate combination of the hyperbaric and hypobaric domains, if you like. This is Houston Space Center, and you're seeing astronauts working in simulated gravity in a pool, and they're supported by divers that are actually breathing nitrox, a 50-50 oxygen-nitrogen mixture. And the reason is so that the divers don't get decompression sickness, and the astronauts are able to essentially simulate the inertia and the microgravity of space. But it comes with tremendous operational difficulties, as you can imagine, the hydrostatic pressures and things that accompany this. But it's just such a beautiful combination of the extremes, and that's really partly what we're talking about. Now, my background in terms of baromedicine really started at the Institute for Aviation Medicine, which is a carryover of the military super specialized unit. So this was dedicated to aviation, but not only military aviation, also the civilian aviation vetting of medicals. So our job included looking at some 100,000 pilots or air crews medicals to determine whether they were fit. But I have to admit unashamedly that my interest has always been on the hyperbaric side and the diving side, so I've always been a bit of the penguin amongst the eagles. But my BSc and MSc have both been in aerospace medicine. I actually went to Duke and poisoned 89 rats with carbon monoxide and did very meticulous reduction gas analyses to try and determine picomoles of carbon monoxide breakdown in tissues. So, it was a wonderful opportunity. So I fiddled around with molecules, and of course we had fascinating situations with alveolar proteinosis that we actually had to treat, and we treated them in the hyperbaric chamber, so you could do the lavage of the lungs in a hyperbaric environment, and if the patient decompensated, you'd have the benefit of additional pressure. So we'd have these pulmonology patients come in, the physiotherapist, basically we flood the one lung, they hit the dust out of the patient and run it down, and then if there's a decompensation, we would be able to treat them under hyperbaric pressure. And instead of spending a week in ICU, they'd sometimes be discharged the next day. So, we had those intersects with your environment, and we also had the privilege of doing some of the trials with NASA, oxygen pre-breathing to prevent decompression sickness. So, I've got a bit of an eclectic sort of interest and background, which we shared in this presentation. Our day-to-day program here is largely surgical patients, often radionecrosis patients, where we try and reverse some of the long-term or delayed radiological complications in tissues. We do a lot of that, especially in the jaw and in the pelvic area. And then from time to time we get emergencies like carbon monoxide poisoning, arterial gas embolism, decompression illness, and then the odd necrotizing infection, if they're stable enough to actually come to us. We're not in the hospital, which is part of the problem, because moving people in and out is a big deal, and you don't want to compromise people in a variety of ways, moving them to and fro. So that limits what we ultimately get to treat as well. Now, in aviation medicine, it's very specifically regulated by the South African Civil Aviation Authority. So there is a statutory mandate under the Department of Transportation that makes provision for aviation medical assessments of aircrew. Different standards, different goals, different classes. That's not important to you, but this is their website, and there is an aviation medical section which you will see includes a large amount of pulmonology. And in fact, this designated aviation medical examiner guide, there are many, many references to pulmonological fitness, pulmonological tests and so on. And in many cases, if we're concerned about a flight crew member, refer to a pulmonologist. Okay? So in the end, the abnormalities will come to your review, and then there will be a case-by-case decision that'll either be settled on medical grounds, in terms of the aviation authority, or go to the courts and ultimately be subject to an appeal process. So in many cases, because this is these people's careers and they are literally high flyers in some cases, eventually the medical decisions are really assessed at court level, at high court level on a constitutional ground, you know, if they go that far. So it's quite a complex environment, but your input is highly valued. We have an Aerospace Medical Association, which you can join as a member. And of course, you've got a bunch of doctors with a passion for this that also have that sort of peer review component. On the flip side, we've got the Undersea and Hyperbaric Medical Association in Southern Africa. And we actually have a database in which all commercial divers, people who dive for a living, whether they're a photographer, scientific diver, do welding or dredge for diamonds, if they actually go for their annual medical assessment, it's logged on a database. This is Divers Alert Network. That's sort of a hotline for diving emergencies. For those of you interested in just the mechanics and the complexities of diving, some of you might know about this cave diver in Bushmanskhat. He was actually a Cathay Pacific airline transport pilot. He dived to retrieve the body of another diver who had died 10 years prior. Ended up giving his life in the process because the maximum voluntary ventilation was what was needed simply to maintain homeostasis. So he was diving to 280 meters on a rebreather system that in the end he asphyxiated even though he had ample gas. So this is a blow-by-blow that I co-authored with Simon Mitchell, who is Professor of Anesthesiology in New Zealand. So that discusses the issues of maximum ventilation, breathing resistance, and it really looks at the extremes. But I'm going to focus on these things, that you know the sphere. Now, the deepest we can go on this planet is the Marianas Trench, which is 11 kilometers down, which represents 1,100 atmospheres. So take the pressure we're at now, multiply that with 1,000, and that's the hydrostatic pressure there. Now, you can just imagine the complexity of work of breathing, gas density, Poiseuille's equation, Reynolds figures, let alone if you have a variable like asthma or compliance issues. Can't be done. So we can't do that. The best we've done is 600 meters or 70 atmospheres. And we'll talk to you about that briefly. And then we've got the flip side, the vacuum of space. But you can't breathe in a vacuum. You can give a guy 100% oxygen, but 100% of nothing is still nothing. You need to then simulate atmospheric pressure using technology, the spacesuits and so on. So wherever we explore, we ultimately run into this difficulty of how do we maintain oxygenation without precipitating toxicity or atelectasis. Absorption atelectasis, or hypoxia, and then on top of that you might be in water, which isn't breathable. So if you lose consciousness underwater, you drown, unless somehow you protect your airway, you've got a helmet or something. So it's not a breathable medium, and those are some of the complexities we need to deal with. Now, if we look at the excursion of the atmospheric pressure, basically you go from the vacuum of space, and then from about 10,000 feet, by the way, the French, I'm very grateful for them because we dive in meters, but the Americans dominate aerospace, so we still fly in feet. Okay? So at 10,000 feet, essentially from there you have a linear decline of atmospheric pressure. So you can pretty much predict on a linear scale what atmospheric pressure would be by function of elevation. But you can see the real business end is the last 10,000 feet. And that's pretty much where most of the unpressurized flying happens. But the pressurized aircraft can go up to about 30 to 40,000 feet, which means that you've got a very, very low outside pressure. And if you lose cabin pressure, you'll have to almost give people 100% oxygen to maintain consciousness. You understand the difficulty there? Okay, so the whole atmospheric column is one atmosphere. But each 10 meters in water is another atmosphere. So we fly in fractions of atmospheric pressure, but we dive in multiples of atmospheric pressure. And it has a very, very significant impact on our physiology. So let me just give you an idea of comparison. This is an excursion of a commercial flight. So there's a Boeing all the way up to actual flying at about 30,000 feet. But the cabin altitude is 8,000 feet by legislation. In other words, for average Joe Soap with COPD, Granny, everybody flying around, 8,000 feet is pretty much the trade-off between how many people you're going to let them decompensate as a result of hypoxia versus the economy of flying at a higher altitude because you use less fuel. So that's ultimately where legislation is settled on. But to give you an idea, this is probably the more meaningful number, 690 millibars, so that's roughly 0.7 of an atmosphere. So when you're at 8,000 feet, you're breathing 70% of atmospheric pressure, and when you come into land, that's going to increase, if it's sea level, to 1,000 millibar, 1 atmosphere. You get that? So 0.7 to 1. That's the excursion in most commercial aviation settings. Now that differential, or 300 millibar, you get that in 3.3 meters when you dive. So your flight descent, which is usually of about 30 minutes, your captain is you fasten the seatbelts. We are now commencing our descent. That part, 30 minutes, gradual equilibration to whatever the landing altitude is, whereas a plunge in a swimming pool already replicates that, and that's virtually instantaneous. So you can see what the pressure relevance would be and the risk for barotrauma in diving as opposed to flying. So here are our strategies and our difficulties. We've got this variable pressure environment. People need to breathe. We need to give them something that will keep them alive. So technically, we need to do it. Physiologically, it needs to be the right composition. We need to, at some stage, control the atmospheric or the ambient pressure artificially. If you go high enough, you've got to start compressing the cabin. And of course, there's the technical aspect. If you give 100% oxygen, you can have a spark and a fire, as happened with Apollo 1, where all 3 astronauts burned to death in, 67. So there's safety issues as well. And we've got this tightrope between asphyxia and toxicity, because if you go above 0.5 atmospheres, pulmonary oxygen toxicity becomes a very, very relevant problem, which is why you want to wean your patients on an FiO2 of 0.5 as quickly as possible, because then your pulmonary oxygen toxicity tapers off. It's not absent, and obviously it can be complicated, but that's more or less, the sweet spot that we try and stay under. If you go hyperbaric and you go to 1.4 atmospheres, you can get enough oxygen delivered to the brain to actually get a seizure. So at 1.4 atmospheres of oxygen, you exceeding the brain's metabolic extraction, which is about 13 mils of oxygen per 100 mils of blood, and therefore you can now have toxicity of oxygen in the brain. You can't get that under normobaric. In the ward you won't get it, but in the chamber you can. So operationally we need to consider the exposure that people have. You can't breathe pure oxygen beyond basically 6 meters, 4 meters, 6 meters. Then it becomes too toxic. On the flip side, we've got the equivalent of 8,000 feet in the cabin, which is 0.14 atmospheres of oxygen. So between 1.4, where operational toxicity becomes an issue, and 0.14, where hypoxia becomes a clinical barrier, we have to now tailor this environment. And operationally, what is usually chosen is a midpoint. So 0.35 is a nice convenient point. It's halfway to toxicity and halfway to hypoxia, and you've got a little wiggle room. So most long-term environments try and stay in that sort of vicinity. Okay, so let me contrast the two. In aviation, we control atmospheric pressure, and we may need to supplement oxygen. The oxygen mask will be released from over your head. Okay, so we've basically got cabin pressure and oxygen masks. But in a hyperbaric environment, we need to start diluting the oxygen out, because the pressure itself is high enough that it's going to become toxic until it's diluted down. And I'll show you an extreme in a moment. And then breathing resistance becomes a problem, because gas becomes dense, and depending on what gas you're breathing, some gases are more dense than others. So these are contrasting challenges we have. Now let me show you what they did at Duke University long before I was there. This little sphere housed 3 men for 21 days. Talk about endurance and interpersonal skills. But anyway, so here are the 3 aquanauts. They dived to 700 meters roughly, 70 atmospheres, and they breathed 0.5% of oxygen. I know, you're giving me this look, that's heretical. I agree if you don't see it in the context of the pressure, because to achieve that 0.35 we spoke about, that would require 35% oxygen here, but at 70 atmospheres, 0.5% oxygen would do that. So they had to basically flap around the atmosphere, because 0.5% oxygen can easily be diluted out, and you're not going to get adequate mixing. But if it goes too high, you're going to get oxygen toxicity very rapidly. So I just want to contrast that percentage only means something if you know the pressure in which it's breathed. And we're a little bit spoilt at 1 atmosphere because 0.5 is 0.5 atmospheres. But that's not true when you go up or when you go down. It's very important then to know percentage in relation to the pressure that you're breathing it at. Okay, so our aviation challenges are mostly hypoxia and hypocarbia, as you know, with mountain sickness. People hyperventilate, they get their respiratory alkalosis, and that sort of thing. Hyperbarics, our problems are oxygen toxicity and hypercarbia, because they can't breathe enough. Okay, so it's the other side of the coin. When we fly, you compress when you land. So if you developed a pneumothorax in flight, coming to land treats it partially, because it'll actually reduce the volume that's outside of the lung. If you dive and you develop a pneumothorax, you get a tension on your way back to the surface. So there are different risk assessments in these environments. Here, you can deal with the issue if you can deal with in-flight incapacitation. Here, you can't, because unless you can put in a drain, the person's going to die on their way back to the surface. So different risk profiling for those two environments. I'm going to outline just where the different activities fit in. I don't want to bore you. I just want to give you a sense or a sampling of what the environment looks like. I'm not going to look at the aviation now because this is the part you probably have the least sort of exposure to. So we're going to look at high pressure on an activity, in other words, what people do, and therapies, how people are treated. In other words, how do we use it therapeutically? So the activities are controlled by occupational health and mining safety. All right, so if you want to dive for a living, then either the mining or the occupational health side is going to control that environment with all the stakeholders and all the representatives. If you're doing a therapy, it's really a medical thing. So it's Health Professions Council. But the difficulty is, what about a commercial diver who's being recompressed for an occupational illness? Okay, you've got bubbles because you dived. Yes, it's a therapy, but it's also provided in a commercial diving environment. So that's a little bit of an oddball because you're doing a therapy in an occupational setting. But for the rest, this is medicine and that's occupational health. Those are two different environments. So the therapies and activities we're going to drill into, and I'll just show you illustrative examples of each, very, very briefly. HBOT, or hyperbaric oxygen therapy, was actually born in South Africa at Karl Bremer Hospital. One of the surgeons here, one of the first deans actually, was responsible for bringing it in for the treatment of gas gangrene. So in 1963, Barton and Van Zyl already published the use of hyperbaric oxygen for infections in South Africa, and it developed in two branches, the infection group and the radiotherapy group. So it was used as a radiation enhancer. So from there, you got transparent chambers because you wanted to give radiotherapy. So these one-man chambers were perspex chambers, and then you had these large metal boiler-like, some almost operating rooms, because they did cardiac bypass surgery before they could do exchange transfusions and that sort of thing. They actually did them in hyperbaric chambers. Okay, so you had these massive chambers like a Duke, whereas I'll show you our chambers in a moment. And the indications we have, some acute, some chronic, but mostly a treatment that's adjunctive to surgery. So HBO is rarely a primary treatment. For carbon monoxide and bubble problems, it can be a primary treatment. In other words, the treatment matches or is the antidote to the problem. But for all the others, it's adjunctive. So it's in relation to surgery, preparation for surgery, support during surgery, or follow-up after surgery. It's not an alternative to surgery, but it is in relation to surgery. Okay, I'll just give you a graphic example. This is one of my patients still in Pretoria, mangled ear. And I don't know whether you'll see it clearly on this presentation. That's prior to hyperbarics. And here you can see the ear pink up. That's within 20 minutes of the chamber. So it's just more diffusion into tissue through the pedicle as a mass action of gas. That's basically what the hyperbarics does. It's not a topical effect. It's a systemic effect. So that's the sort of thing we can do. And our role as doctors is basically choose the right patients, make sure the environment is safe, and make sure that the facility itself is safe for both staff and patients. So that's our responsibility. The other side of the therapy, of course, is now what I said, the gas bubble disease. And this is the sort of environment in which that hyperbaric oxygen is provided. It's not exactly sterile, it's not convenient, and it can be in a very, very hazardous environment. But it's pointless suggesting that these divers be flown to a hospital chamber because they'll be dead before they get there. So we have to deal with the occupational emergency by providing on-site recompression. And this then falls under the diving regulations, not the Health Act. You follow? Now, doctors involved, but the diving supervisors are the primary authorities there. So we provide telemedical input. And this is usually what we do. We supervise, we make sure the diving regulations are followed, we deal with the operational aspects, and if the emergency, sometimes surgeons will actually be taken into the hyperbaric environment and they'll have to operate on a person who's at 150 meters equivalent in a chamber. You can't wait the 2 weeks to get them out before they're treated. So that's the sort of life of hyperbaric surgeons. Now, from the legal or statutory landscape, very, very simply, the activities fall into two categories, wet and dry. And dry can either be a chamber, in other words, like a nurse or paramedic or doctor working in a pressurized environment for patients getting hyperbaric oxygen. That is in a form of professional pressure exposure, right? Or you can have people working in rivers, building pylons, digging out the muck at the equivalent of whatever the riverbed or the lake bed pressure is. Because you have to pressurize this inverted bucket. I don't know whether you can see it. This is the Brooklyn Bridge, actually. That's where Caisson's disease or the bends was first coined. This is an inverted gas space, and these are individuals digging out the buck. But they pressurized to the equivalent of about 15 meters, and many of them died, okay, because they didn't know about decompression illness then. This is like the Gautrain. We were involved with the Gautrain Rosebank section, which was 70 meters underwater. It had to be pressurized, and people who were servicing the blades were simple laborers, but they had to go through these hatches, and they were pressurized in that environment and had to do the servicing basically as divers. But they were dry. Okay, so it's a dry form of diving, if you like. Wet can either be professional or recreational. The professional side is typically two categories: if you work for a living or you mine for a living. And the difference is that falls under occupational health, that falls under mine and safety health. Okay? Those are different, there's similarities in how they deal with it, but they are different regulatory structures. So it's just important to know about that difference. I'm not going to bore you with how the Constitution stratifies out to where you've got your technical guides, but essentially you've got the Constitution, all animals are equal, some animals are more equal than others. Okay, that's a joke on Animal Farm, those of you that read the book. Okay. So that's the basics. Then you've got the Health Act, Education Act, Then you've got the regulations that actually bring it down to a practical level. Then you've got codes of practice, which are the ways in which industry then implements the regulations. And this is like the Bureau of Standards that says, okay, this is how it can be done properly. So this is a stratification. And it's very useful to just keep that in mind when you look at the different levels of legislation. Now, in terms of diving, as I mentioned, you've got occupational health for people who are diving for a living, but not mining. And then you've got the Mine Health and Safety Act for those who are diving for treasure, okay, for diamonds, alluvial diamonds off Alexander Bay and so on. So just be aware of that. I won't cover the other laws, they're on the slides. You can have a look at them and how other countries have dealt with them. But in summary, you've got South Africa that really makes it management's responsibility. So in other words, management, if you injure your employer, whether you took a chicken in return for the work they did, or whether they're formally employed, doesn't matter. You're the employer, you're responsible for their health. You're responsible for their safety. Whereas in Canada and Australia, there are very, very strict prerequisites that are imposed prior to determining a person is fit to work and to control the environment in which they dive. So it's just a different landscape. There are industry champions. This is the Maritime Contractors Association, so a bunch of shipping and diving folks that get together. They've got a medical council of advisors, and these people weigh in on what the codes of practice should be in the different areas of commercial activities in the oceans, whether you splash on the surface or whether you submerge. So it's just something that you should know about. Professionally, we've got the military. And this is a bit of a paradox, because here they need to comply with occupational health stuff, but it's quite all right for you to blow yourself up in a war situation. So you've got the paradox of hyper safety in peacetime and all bets are off in wartime. And so they can't really fall under specific legislation because you can't keep it up. You know, it's all's fair in love and war type thing. You can't really put that into the framework of regular occupational health. But in peacetime, they're very, very stringent. The biggest bulk of diving is recreational diving. And those are the splashers and breath hold folks and the people who breathe on a compressed gas source, also called self-contained underwater breathing apparatus. Okay? Many schools, many different institutions train them. They've got a standard medical assessment they've agreed on, which is simply to reduce the liability of the training organization or the instructor. There's no legal mandate for someone to have a medical before they do their sport. I mean, you don't go for a physical before you climb Table Mountain. But the difficulty here is if you train someone, you need to tell them about the risks. You need to make sure that those were properly assessed. So the person can lie in the form and say, no, nothing applies. And then they made a decision. If they say yes, a doctor needs to sign them off, not even a diving doctor. So that's how recreational diving works. Commercial diving, you need a formal, designated medical practitioner signing them off. So that flips. So we look at physical, mental, and social responsibility. And what I mean by that is you're meant to dive with someone, and the assumption is if they're in trouble, you'll help them. And if you're in trouble, they'll help you. So if you've got some sort of medical condition and you decide to dive, you are actually socially irresponsible because you're imposing a risk on the other person that they may not be aware of. You follow? And unfortunately, people are rather selfish in their decisions to dive with medical conditions, but this is the leverage point, and in terms of actual diving fitness in the recreational setting. This is the training hierarchy. You can start snorkeling or scuba and become a dive leader, or you can just do different stuff, different activities. So you've got people that really don't go beyond their first course, people who dive on holidays, collect badges, or do extreme stuff. All right, and the dive leaders we spoke about, basically people who are tour guides and people who are instructors at different levels. So this is the last focus point, and I just want to show this to you because this is where your decisions are going to come in. We've got two gross gas bubble problems. We can, Boyle's law, puncture and blow somebody up, or we can develop bubbles so that they get decompression illness. Okay? There's an overlap because venous gas bubbles can arterialize and give you embolic phenomena. So it's not a crystal clear division, but it's essentially lumped under decompression illness. It is far more likely in divers than in pilots, for reasons that I've already mentioned. There's a specific distribution, but it can vary. There are obviously risks of ear barotrauma. That's the most abused organ in diving and flying, actually, because of the pressure changes. There are plugs you can wear with flying that do protect the ear a little bit and slow the pressure down, especially for children. You can't do that in diving because essentially the pressure differentials are too great. So just be aware of that. Vision's obviously not ideal when diving. I mean, if you can see your hand, it's a good day's diving in commercial diving. In flying, we rely on visibility for the most part. Color vision is relevant in diving. You know, cut the red wire, which one? You know, you need to know signals and landing and that sort of thing. So color vision is relevant. And in your field, bullae, for instance, are completely different in terms of flying or diving. If you have a spontaneous pneumothorax as a pilot, you can have firstly, landing makes it better. You can eventually, after a second episode, do a pleurodesis. And if the risk of barotrauma is solved or collapse is solved, the problem's solved. With diving, it's not the case. Even if you do a pleurodesis, you've still got bullae, and those bullae can inject bubbles, and you can cause fatal gas embolism. In flying, it's a relative contraindication. In diving, pulmonary bullae is an absolute contraindication, because you cannot prevent the gas bubbles being injected. So it's an important contrast. This is actually a patient with Marfan's, a doctor's son that we didn't know about that until he embolized. So anyway, he did well. We spoke about buddy issues and training and credentialing. You've basically got doctors with an interest in diving, and you've got doctors that specialize or subspecialize in diving medicine. In Europe, it's a specialty. In America, it's a subspecialty. But that's essentially where it's at. These are the courses we run here: underwater, or hyperbaric medicine. And if anybody's interested, the first level gives you a fitness to dive or fitness or selection for hyperbaric oxygen therapy level certification. So you don't need to do the whole degree. You can just have competency at that level. Or you can go to operational diving or operational hyperbarics. You can go to the advanced research and then ultimately get your BSc, Medicine and underwater or hyperbaric medicine. And of course, if you haven't done that before, that can take you to an MSc if you want to. So that's essentially how the academic hierarchy works in our respective fields at the moment. But it's not an MEd, so it's really on the MSc track. But it is recognized as an additional qualification by health professions, and obviously there's the peer review aspect that's relevant. This is all the certifications we have in terms of the training. It's recognized internationally. And that's it. So we've covered baromedicine very quickly, the pressure-oxygen continuum, what you breathe matters on where you breathe it, what the pressure is, the medical clinical landscape, how it applies, the legal statutory landscape, nothing, occupational or mining health, the clinical and operational contrasts, oxygen and low carbon dioxide, oxygen toxicity, high carbon dioxide in the different environments, and training and certification. So after our 9-month apprenticeship of liquid breathing on cardiopulmonary bypass, we are born into an ocean of air, and as a result, diving medicine is managing that discrepancy. And I hope that was interesting, and I hope maybe it's challenged you and interested you to get to know more about this fascinating field. If you'd like, there's my email address, and I'd welcome any questions at this point. Thank you very much.